Hello, I'm Dipti Itchhaporia, and I'm joined by Dr. Dr Chew at the ESC meetings, and we're going to be talking about the RAPIDxAI trial. Welcome, Derek.
Thank you very much.
So tell me about this RAPIDxAI trial that you are going to be presenting.
So, as you know, artificial intelligence is the innovation, the technology of our era, and the question that we really wanted to try and get to the bottom of was whether or not we could use artificial intelligence to help with that difficult problem in the emergency department of helping clinicians diagnose type 1 MI in the mix of all the other forms of myocardial injury that they see, and whether or not that can actually improve care and outcome.
Okay, so tell me a little bit about what you did to get to the trial.
What we needed to do was we needed to embed an algorithm in clinical practice. To do this, we needed to build an architecture that would gather basic biochemistry and hematology information, clinical information, and then ECG information, send it to the cloud, make a diagnosis, present it to the clinician, and provide them with some advice about what to do with that information. You can imagine that was kind of challenging. It took us a year and a half to actually put the architecture in place. But then we cluster randomized the study. We took 12 hospitals, randomized half of them to receive the decision aid and the other half not to receive the decision aid. And we could use the health system to see these patients coming back with recurrent events, particularly recurrent cardiovascular events, out to 6 and 12 months.
And the thought was that the decision support could potentially change the outcomes in these patients.
We know that junior doctors, interns, residents in the emergency department have difficulty working out, based on the fourth universal definition, whether or not this patient's a type 1 MI that needs a coronary angiogram, or whether or not they're type 2 or acute injuries that don't need this form of management, for which we still lack a lot of evidence base for. And so we thought that potentially by guiding that decision, we might be able to get better guideline adherence and better translation to improved care.
So tell me, how many patients were enrolled?
So in total, we needed to capture patients at the point of entry into the emergency department. So this being cluster randomized, in 7 months, we actually included over 16,000 patients and then randomized 14,131 patients to across those 12 hospitals. Of those, 546 patients had myocardial injury, and those in our primary analysis data set, those patients who were of primarily cardiac assessment, was 3,029 in the two cohorts.
So I want to make sure I heard you right. That's a very quick enrollment for that number of patients.
Again, our strength was we were embedded in the health system. That was the ambition from the beginning, that we could use the digital architecture not only to identify the patients and include them, but also use them for follow-up. This means that our database lock for this presentation occurred 59 days ago.
But it seemed like a lot of the work happened before you started the trial.
It was a great challenge. And everybody is focused on the development of the algorithm. That took 3 weeks. The development of the architecture to be able to deliver this to a clinician with a data latency of 30 seconds took us over 12 months to achieve. But once we got there, the infrastructure is there, sitting in the background for all these clinicians.
So I'm at a hospital where I am receiving that decision support, and I'm the clinician. I get whether this is a type 1 MI or not. And is it up to me to decide to use the recommendations, or do I have to follow the recommendations?
So our intention was to nudge, to encourage, to just provide further insight to the clinician. We did not force them to do one sort of therapy or another. It was very much a suggestion that we made to the clinician.
All right, so I'm curious to know, what were the results?
So what we found is that there was a slight nudge in those patients with type 1 MI, where the algorithm identified the type 1 MI, where there was an increase in statin use and P2Y12 inhibitor use, a little bit more use of mineralocorticoids, but no difference in the rate of angiography or the early invasive strategy. In those patients with myocardial injury thought not to be due to a type 1 MI, there was a reduction in invasive management and a slight reduction in beta blocker use. But overall, these these modest changes, though statistically significant, weren't sufficient to dramatically impact long-term outcome, at least to the 6-month mark.
So why do you think there wasn't a change in the invasive strategy?
I think we need to think about AI and insights into the systems of care and the environment we land that information in. That sometimes it is still easier to follow the rules and the norms and the practices that have already been established in those hospitals, and overcoming that by simply providing one bit of insight is often a too high a bar to reach. That if we're going to change practice with AI, we're going to need to be much more sophisticated about where along the decision pathways we actually embed those insights to change practice.
So are you saying the clinicians didn't actually believe what the AI algorithm?
I certainly think that some of the clinicians didn't believe or wanted to practice in their own way. That there wasn't enough impetus to see a change. Clinicians are trained to judge that to trust their own judgment and
Right.
make the call, and it will take a while, I think, for us to give over that agency of making that call.
What about the percentage of people where they were nudged to say this was safe to go home?
So certainly we saw that in the very large proportion of patients who were identified as, we actually calculated their risk of 30-day death of myocardial infarction. And in those patients, the rate of events was equal, if not numerically lower, in those with the availability of the decision support. So we know that the tools are safe in their ability to identify patients for discharge.
Were you able to verify that what the nudges were, what the algorithm was actually accurate?
So certainly when we looked at the performance of the algorithm, we could see that patients who were identified as having type 1 MI had a higher rate of recurrent myocardial infarction. You would expect that if that's what the algorithm is supposed to phenotype or identify. And certainly in those patients that were sent for invasive management, identified by the algorithm as being type 1 MI, there was a reduction in events in those patients, predominantly in cardiovascular death and MI. If the algorithm coded you or phenotyped you as being not type 1 MI, getting sent for angiography made no difference to your outcome. So it does appear to appropriately phenotype patients and remains so. The harder part now is trying to get people to follow that practice.
So did you interview any of the clinicians to see how they felt about you utilizing this?
In fact, we did. We actually ran a parallel study, quite a detailed study, where we interviewed people before and after the use of it. Trust is an issue for clinicians, and so relatively low trust levels. Interestingly, the trust levels were as you would expect them. The highest levels of trust are in our system fellows, or
Right.
in fellow level people. Staff specialists were slightly less likely to trust, and interestingly, interns and residents were slightly less willing to trust the AI as well, which was a little bit surprising to us.
Well, maybe they felt they didn't know enough to be able to trust that.
And that's probably true. That's probably very true.
So just to go back, so what are some of what I heard was it took a long time to build the architecture. Well, once you did, it wasn't that long to do the algorithm, but also then enroll the patients. It's phenomenal that you did this in such a huge number of patients in such a short time that, it really didn't change the outcome, but there are some lessons learned. So tell me about some of those lessons that you learned.
So a few things I think from this experience. The first is that the digital architecture of how we, in our complex workflow of healthcare, should not be underestimated. The amount of investment required to embed AI into healthcare will be very large and need to be implemented at a local level. In other words, you can't ship in something from somewhere else. It is going to need to be required dedicated local investment. The second thing is that it will require a little bit more sophisticated thinking around how you move other drivers or system factors towards that. Availability for angiography isn't likely to influence how people practice. Availability of the other investigations along the lines of the advice from the algorithm will make it, will drive differences in practice as much as the AI itself. So a deeper integration between the insights that AI provides and system changes, like any innovation, is going to be critical if we're going to actually leverage those benefits.
Now, we're at the ESC meeting, there's a lot of new science coming out. When there's new science that changes what you would do in terms of the algorithm, would that be a lot of work to try to change that?
Well, the beauty of being embedded in a health system, though, is that the opportunity to keep refining the algorithm, to keep validating it, because the data is just continuously flowing, and you can continually update that information and or work it in and randomize another set of questions within that environment. In effect, we've built a platform for that is based on a digital technology, digital architecture that enables us to look at not only new AI approaches, but also other therapeutic innovations in this space, which we desperately need to because of all these patients with type 2 MI and acute injury that we know have poor outcomes, but we don't have any evidence-based therapies for this.
So where are you going to go from here?
Well, the next steps are a whole multitude of approaches. First one is that we're looking at other types of health service interventions. Can we get chest pain nurses to use the algorithm more diligently and see whether or not that improves efficiency and outcome? We've identified a large group of patients who have recurrent heart failure admissions that are beyond those of type 1 MI. So we'd like to test, SGLT2 inhibitors in this population of patients. We're interested in the impact of vaccination, particularly for influenza and RSV, as we know that they're precipitants for these recurrent events. In effect, what we've established is a cardiometabolic platform where there are higher rates of readmission for heart failure and arrhythmias identified by myocardial injury. We want to explore therapies in that space.
There's so much interest in AI, and everywhere you look, everybody's thinking the AI is going to be an overnight thing. But what you're telling me is that this is going to be a process and a huge investment, but that slowly but surely we can chip away at it. But it is going to be at a local level with a lot of investment for it.
It's absolutely the case. To achieve this, we needed to get buy-in and commitment from the digital architects, the data science engineers inside the health system. But we also needed to get investment from health services and the state health department to invest and get the commitment that really took most of the time. The engineering was and the development of the algorithm was actually the smallest part of this. It was dealing with issues of privacy, dealing with issues of ethics. Those sorts of factors are key drivers in how you actually...
So then do you think it's cost effective in the long run? I mean, think about someplace like the United States. And if it's all done at a local level, that's a lot of money spent to do all of this.
This is why I think that, and why we've actually gone down the road of doing it in a research framework, where we actually want to value, I want to know the effect size. If the effect size is big, then it will be cost effective.
Right.
But if the effect size is really small, then, or there is no effect, then you're absolutely right. It will not be cost effective.
But there's a lot of money spent even to get to that point, right?
Exactly.
So
we need to develop sophisticated and more efficient ways of validating the AI. Once we feel that we're in the health system now, we're embedded, and so our ability to test the next question a little bit more efficiently will allow us to value those things down the track. So there's this initial hurdle that you do need to get through.
But can we learn from you so that if I'm doing it at my institution or where I am, it will be faster and maybe more, I don't have to do as much?
I think we can. I think that we can share where the hurdles and the barriers are. The technologies for implementing it it continues to expand very quickly, and being able to put the algorithms in the cloud and connect is moving ahead in leaps and bounds. So I think that like all things, the initial investment is much higher than it will be in future years, but I still don't underestimate the likelihood that demonstrating cost effectiveness requires an effect size, requires proof and ongoing validation that it's actually providing a benefit.
So I'm going to ask you the last question. Do you think that in our lifetime you're going to see AI permeated all throughout our healthcare system?
Permeated all throughout? I think no. I think that in sort of rarefied, relatively bespoke areas, that I think we will see it more extensively. I actually think that the first place that it will get more widely instrumented is in clinical trials, because that's where the investment is going in, getting back to your point of cost effectiveness. The cost effectiveness of running clinical trials in clinical practice is much more efficient through an AI process.
So it sounds like you're a believer in using AI specifically for the clinical research piece and getting patients enrolled quickly and in a huge number.
It's like any technology, like a drug therapy, device therapy. I think it needs validation first before you actually go widespread. The advantage of being embedded in the system is your ability to switch over and go widespread is enhanced in that it's easier.
And you reminded me of one other point that was really important. I noticed that it was almost 50% women in this trial, which, you know, we're all trying to get sort of gender parity, so trying to get the numbers up.
Being embedded in the health system means that you can deal with some of those selection biases and other biases that at least influence our research. We can, we need to do the opportunity that AI offers and the digital architecture is to operate at scale. And what we mean by at scale is entire capture of whole populations.
So anything else that you want to share about the trial that I didn't ask?
No, I think that you've covered most of it. Thank you very much.
So thank you so much.